I'd like to welcome everybody. Let us start our distinguished speakers, our attendees. Thank you very much for attending with us this very special webinar. What makes it special is that it is going to talk about cardiometabolic series, our practice during the COVID era, which is actually a very challenging era. Our point or objective of having this collaboration today is to talk about different aspects from different experience. We will, inshallah, go within the schedule. We will try our best to focus on what did we do and what is the practice during this COVID era. I would be glad to start with Dr. Faiz Ashar. Dr. Faiz Ashar is an associate professor in King Saud University Hospital. He is a heart failure specialist, and our consultant in even the ECHO in King Saud University Hospital. He will tell us about the hypertension experience during the COVID era. Dr. Faiz, can you please start?
I would like to thank Saudi Heart Association and the organizing committee for inviting me to that very important webinar with this constellation of friends and colleagues. And the topic was given to me, the challenges in the management of hypertension during COVID. We know that COVID usually affects the patients who had cardiovascular disease, and by itself, it will cause more cardiovascular damage and derangement. So I will try to shed light some important point on hypertension and COVID-19, hypertension correlation with diabetes, and the protective measure taken by WHO, and the interaction between COVID and ACE2, especially this enzyme, and the debate about using ACE inhibitor or ARB and recommendation, then we go to conclusion. We know that the prevalence of hypertension is around 30 to 45%, and it is a lifetime increase with age, and the more aging the population, the more we have hypertension. And it is not only hypertension, there is a lot of risk factors like overweight, diabetes mellitus, renal failure, hypercholesteremia, mental stress. So the patient had a constellation and multiple comorbidities. And even though only 30% of those patients treated are controlled in Europe and also in our Middle East area. COVID is a severe acute respiratory syndrome caused by coronavirus, and it is expected that the number are increasing because of a lot of asymptomatic, mildly symptomatic, and undiagnosed cases. And now currently we are in the era of second wave, hopefully not. While focusing on the novel coronavirus, there is a danger that other illnesses might be overlooked and maltreated. And patients are being urged not to go to the emergency room because for non-urgent matter, with a dual intention of protection of healthcare provider and saving the resources to treat COVID. So what happened in the hospital? The hospital reported that there is a reduction in cases of MIs and CVA presented to the hospital. Not only that, but there is a late presentation myocardial infarction with its complications because the patients are reluctant to go to the emergency room in order to avoid contracting viruses. Management of stable chronic illnesses like hypertension and diabetes also affected because we just renew the medication and we call the patients without rechecking their labs or their blood pressure regularly. So what are the measures taken by the hospitals? That the hospital canceled all in-person elective patient care and only outpatient clinic virtual via phone call or via Zoom, and moved towards telemedicine and because of applying the social distancing. The aim is to preserve resources and to help tackle supply chain problem for COVID. And it is imperative that those life-threatening conditions are not to be forgotten. Patients with COVID-19 admitted to the New York City found that 50% of them had hypertension, and 30% obese, 25% diabetes, and overall mortality 10%. So it seems that all hypertensive patients are more prone to develop COVID. And the data came from China and the United States suggested that hypertension appears to be the most prevalent comorbidity among these patients, and reaching up to from 30 to 49%. Hypertensive patients with COVID, they are more likely to be admitted to the hospital than normotensive, and they have poorer outcome from COVID. And also, whether we don't know whether hypertension per se contribute to the increased morbidity or hypertension associated with multiple comorbidities. So hypertension is only considered as an association and not as a causation. So we come to one important point: hypertension and diabetes mellitus. This is a cardiometabolic syndrome. We know that the persons at risk for developing diabetes if their blood pressure remains uncontrolled more than 140/90. And those patients who are diabetic and their pressure is exceeding 130/80, they are more prone to more cardiovascular complications. Risk factor for developing diabetes, one of them is hypertension and hypertriglyceridemia, abnormal lipid profile, sedentary life, and obesity, and all these are risk factors for development of diabetes. Diabetes, we have a disease, a pre-diabetes, which is considered as a disease and need to be diagnosed. And we have the fasting blood sugar from 100 to 125, and the postprandial from 140 to 200. And this is on 3 measurement, and also hemoglobin A1C exceeding the normal level, which is 6.4. So pre-diabetes is a risk factor, because we know that those patients who had normal compared to impaired glucose level, glucose tolerance or insulin resistance, they have still increased the risk of cardiovascular disease prior to diabetes mellitus compared to new onset diabetes and long-standing diabetes. So pre-diabetes is very important, that those, not all of them, they will develop diabetes, but in one study showed that about 29% and 50 to up to 55%, they develop diabetes in 3 years. And the other trial, longer duration, when and the percentage is high when I need to move this images. Okay, here. And other trial, longer duration, these rates increased from 34% to 68% over 6 years. They follow those pre-diabetic for a while, and they found that there is a 5% annual progression to diabetes, and there is about 20% they develop cardiovascular complications. 6% of them, they develop cerebrovascular complication, and 8% peripheral vascular disease, and 8% retinopathy, with albuminuria and nephropathy in 4%. And the more you have multiple comorbidities, the more you have the complications. So diabetes mellitus, there is increased incidence of and the severity of infection. Why? Because diabetes, we have a defect in innate immunity and phagocytosine, neutrophilic chemotaxis, and cell-mediated immunity. Also, acute hyperglycemia in the upregulate the ACE2 expression, which is facilitated for the viral mechanism. And also ACE2 is present in the pancreatic cell and the beta cell, and that's why acute hyperglycemia might cause more damage to the pancreas, and this might induce new diabetes or worsen diabetes. So what was the recommendation? Recommendation: patients with diabetes and hypertension may be at higher risk for complication of COVID-19, and we need to monitor the blood pressure and the blood glucose level regularly. And even we need more strict control in this era of COVID than previously, because of the risk of the infection. Then we come to a very important point, which makes a lot of fuss about this, ACE2 and the potential therapeutic implications. If you look at here, you found that sympathetic activation will lead to stimulation of juxtaglomerular cells in the kidney, and this will activate renin, which will convert angiotensinogen to angiotensin 1. This angiotensin 1 under ACE enzyme will convert to angiotensin 2 with its vasoconstriction and inflammation. And ACE2 will form angiotensin 7, 1 to 7, and this is called counteracting mechanism, vasodilation and anti-inflammation. ACE2 is counter-regulatory enzyme that degrade angiotensin to angiotensin 1 to 7. Thereby, angiotensin 2 effect attenuate the angiotensin effect of vasoconstriction, sodium retention, and fibrosis. Demographic data showed that there is an increase in ACE2 in old age and in male sex without using ARBs. And also data suggests that ACE inhibitor and ARB upregulate the ACE2. ACE2 and ARBs could also have a potential deleterious effect. Why? As ACE2 widely expressed in the cardiovascular system and in the lung, and it is upregulated, so there is a chance for more action or more work for the COVID. What are the mechanisms? How the coronavirus work? The coronavirus lead to injury of the lung cells, primary type 2 pneumocytes, and binding to its functional receptors, the receptor of this enzyme. And this will be endocytosed, and that's why be downregulation of the ACE2, and this will lead to unopposed angiotensin 2 accumulation. Also, in the lung, there is an activation of angiotensin 2, which may lead to more lung injury. So you have damage of the protective mechanism, and you have activation of the angiotensin 2, which is more harmful. What another mechanism that COVID can cause increased intravascular coagulation, and not only hypercoagulability, not only because of COVID, but maybe due to inflammation, due to hypoxia, due to immobilization, due to dehydration, and diffuse intravascular coagulation. Also, hypertension per se is causing hypercoagulation, lead to worsening metabolic milieu, and the interaction between SARS and ACE2 in the endothelium cause endothelial dysfunction, and endothelial dysfunction will lead to activation of the thromboembolic complications. So this is the bad face, or the one face of the coin. The other face is the counter argument. We can say that ACE and ARB reduce the systemic inflammation and could potentially reduce the degree of multi-organ failure seen in COVID-19. Significantly, there is a higher T cells and trend towards lower interleukin 6. And an experimental model found that the ACE has a protective effect for lung injury. If we say down regulation of ACE2 by COVID associated with severe lung injury, so we need an ACE inhibitor and RB, which will increase the ACE2, which can counteract the mechanism of damaging of ACE2. And by limiting the effect of angiotensin 2, ACE2 could also protect against a more severe COVID infection. Discontinuation, if we discontinue ACE or ARB, what will happen? The morbidity is increased because of uncontrolled hypertension and uncontrolled heart failure, and this causes more damage to the body. So data have raised the possibility that patients treated with ACE inhibitor or ARBs have a better outcome. What is this data? I will shed light on few data of them. 9,000 patients in China found that cardiovascular disease are at increased risk of hospital deaths, but there is no association with increased mortality with ACE or ARB. Another study from China found also that all-cause mortality was lower in patients using ACE or ARB compared to no ACE or ARBs. And also another study showed that fewer patients on ACE inhibitor or ARBs had severe disease as compared to those without ARBs. So currently, overexpression of ACE2 has no impact, negative or positive, because of conflicting data. And until now, there is no clear evidence that blocking RAS system is harmful, and the need for more research in the area is of paramount importance. What is the recommendation? Patients on ACE inhibitor ARB should continue because the guideline confirmed the benefit of these medications in reducing the mortality. And withdrawal or with switching to another medication is not advisable. Major clinical societies recommended continuing using the important drugs, as per guidelines like the American College of Cardiology, American Heart Association, and the Heart Failure Society of America. And this is a position statement of European Society of Council of Hypertension, ACE inhibitor, that we have to continue medication and not to discontinue. Another point, beta blocker. Beta blocker, we know that it inhibits the sympathetic nervous system. That's why it decreases the renin, and it will inhibit renin by its both arms, the ACE1 and ACE2. And it was found that beta blocker used in COVID reduced the mortality in septic shock, and also has a beneficial effect in patients with ARDS and respiratory failure. And this study is an association between antihypertensive drug used and outcome. And it was found that ACE inhibitor and RB have a neutral effect, but beta blocker has the best effect as an antihypertensive compared to calcium channel blocker. And this is the recommendation of that trial done in Netherlands and Germany. No evidence for adverse outcome in severely affected COVID. And beta blocker was associated with a significantly better outcome, whereas calcium channel blocker was associated with a poorer outcome. So in conclusion, continue the guideline-based management for all chronic conditions. A healthcare practitioner need to ensure that the patients are appropriately counseled and have access to their drugs. This is the time for much more control of chronic illnesses. And we are still learning more about the new virus, and the information continues to mount. We should remember that other diseases and illnesses are still out there and they still need our care. Get used to the new normal way of life, and we have to ensure that patients with chronic illnesses are not forgotten in our fight against COVID. Thank you.
Thank you very much, Dr. Faiz, for this informative presentation. And now it's time for Dr. Kamal Al-Ghalayini, Associate Professor, Consultant of Cardiology, specialized in heart failure in King Abdulaziz University in Jeddah. Dr. Kamal will tell us about the heart failure programs and their control and role in the COVID crisis. Dr. Faiz and all the panelists, we will have our questions at the end of the webinar. So Dr. Kamal, can you please take the podium and start?
Yeah, thank you. Thank you very much for this introduction, Dr. Fakhr, and thank you very much, Dr. Faiz, for such a comprehensive presentation on this controversy of hypertension and antihypertensive medication. Once again, I would like to thank the Saudi Heart for organizing such important hot topics of the hour, and especially the heart clinical pharmacy working group. So without further delay, if you allow me to present, So I will be presenting the role of heart failure programs during the COVID-19 area. As we know that it's the gold standard of care for heart failure patients to have a heart failure program in order to come with the best results. Where do we stand? I got these this morning. So we have a total of 34,400,000+ patients. That's worldwide. And unfortunately, the total this has passed the 1 million patients. Saudi Arabia alone stands for more than 335,000 patients, and alhamdulillah, our total deaths did not pass beyond the 4,700+ patients. It is big, and we know that a big burden of communities is heart failure. We know that 2 to 2.5% of any nation has heart failure patients. So these patients are in jeopardy for such disease. That's why at the beginning of the pandemic, the Saudi Heart has asked the Saudi Heart Failure Working Group to come up with management recommendation, and it was done, and later on it was published in the Saudi Heart Journal. So these recommendations were basically looking at the safety of healthcare providers, the safety of heart failure patients, recommendations for emergency department, this is the main gate for our heart failure patients when it comes to decompensation, and management consideration for hospitalized heart failure, and recommendation for outpatient visits for heart failure patients, especially that almost 90-95% of our patients are actually an outpatient visitor rather than admissions, alhamdulillah. And that was the classification adopted for prioritization of attendancy in the ER, and it was the recommendation of the group to adopt it for heart failure patients. And then for hospitalized heart patient, we had a recommendation that all patients hospitalized with heart failure needs to be screened for COVID-19. And for acute decompensation heart failure, we don't recommend any specific changes in their pharmaceutical management, but we do encourage an aggressive diuresis to shorten their stage. And in case of deterioration, you will have a more dry lungs. That will play a much easier role for our intensivists when they deal with deoxygenated patients due to COVID infiltration. And plus that, it was encouraged to actively early discharge planning and ensure that patients are discharged as soon as possible. Patients with acute decompensation with positive must always be handled with airborne precaution, just as any other patients. And due to the dilemmas of new drugs and new uprising drugs, especially such as dexamethasone, and we know that it has a big burden on fluid retention, and other drugs, and especially the anti-malaria things with bronchitis. This is our recommendation to keep an eye on the drug-drug interaction. Usually, this is the major one of the key rules for our fellow clinical pharmacists who rounds with us on our patients. The recommendation for referring to the Saudi guidelines for management of heart failure was there. Now for outpatient visits, at that time, we called and urged to cancel all in-person visits. You know that at the beginning of the recommendation area, at the recommendation of the COVID area, there was a lot of lockdowns, a lot of restrictions on movements. So we urged on canceling these appointments. Even if we don't, it will be canceled either ways. And we can encourage self-monitoring, remote monitoring through getting the patient to check their weights and vitals at home and report them virtually to their healthcare facilities. Establish and thinking and outside of the box, and at that time it was outside of the box, but now telemedicine and platforms are really taking over and helping a lot in managing these patients. Now continuing all anti-failure therapies, including RAS blockers, and Dr. Faiz has elegantly showed the pros and cons of this and the final recommendation for the practice. Now, unless indicated, avoid significant change of medication prescriptions, especially that at that time patients were at home. And of course, cancel all their elective procedures and practice resistance in all communications. Sorry, practice reassurance in all recommendations. And this was highly recommended by the group. At this point, we are really proud that we mentioned this. The amount of depressions between our heart failure patients has been significantly increased. We believe that but we didn't study it, but we believe from expert observations that it's related to lockdown, family restrictions, and ability to get out of the house, fear of being infected, especially that the media says, also the literature that People who have chronic diseases, heart diseases on medications are the most liable to die from this pandemic. All this has created a huge pressure on our patients and pushed them into depression, which already they are vulnerable for. So reassurance from the medical care team, providers had a very, very strong indication at that time, and we believe it still has a very big role. So we recommended a virtual clinic, and we created some sort of a pathway that can be predicted. So they are connected through phone, our patients, review the patient medical records. So you are talking to the patient on the phone. At the same time, your laptop is in front of you, and the hospital information system is allowing you to access his records. And then you start practicing your visits through their family, check blood pressure, home monitor if available, try to get one from the closest pharmacy, get the patient weight, and the so on routine that we do in clinic, in order to have a recommendation at the end of the day, at the end of the at the end of the interview, regarding adjusting medication, probably some salt restrictions or walking inside the house, and etc. and etc. Now, in King Abdulaziz University Hospital, we have a multidisciplinary team. We've built it over 5-6 years right now, and it was started with a survey at that time that covered 150 beds, 860 admissions, more than 600 patients. And we found that heart failure is the #1 cause of hospital readmission. And for the unplanned hospital readmission, we found that heart failure is actually the furthermost common cause. So from that on, we had a look at our service, and we looked at the standard care of cardiac patient. There was a regular appointment, unfortunately, interval 4 to 6 months. There was no open access for our patient, no patient education at the definition of heart failure, patient education. No direct specific clinical pharmacy services were involved. No heart failure nurse specialist to run the disease. No outreach calls, no outreach elective educational message, and no collaboration with electrophysiology services or other specialties. Alhamdulillah, once we establish this, right now we have appointments 3 months or as needed appointment. I mean, we can see our patient in a week, and sometimes twice a week if we want. We create an open access, open door policy for our patient. That requires a lot of dedicated personnel and a lot of operational logistics. We had our educators by our side, dedicated, the heart failure patient educator, lucky enough to have a heart failure clinical pharmacist who will be working with us in every clinic. And sure, we could not have done this without a heart failure specialized nurse. Outreach calls and education messages and collaboration is a solid rock right now. And this is part of our practice. This is our clinical pharmacist. He's actually a friend of Dr. Fakhr. This is our clinical nurse. And this is our colleague, my colleague, Dr. Ridesi. And this is proudly our patient educator. And you can see his office and the various educative material, real life things that he works on. Going through quickly our routine sheet that has the demographic material and then the data of the disease, electrophysiology correlation, and our clinical pharmacy sheet, and then education, and finally by recommendation and outcome. And then we have our jewel of the program, which is, we call it the LASIX room or diuretic infusion room. We built the guidelines for admission, infusion protocols, discharge guidelines, follow-up, And then we looked at decompensating 200 patients needing admissions over 2 years. And we published our experience about 3 or 4 months ago, the effect of diuretic infusion clinic in preventing hospitalization for patients with decompensating heart failure. And the results were only 14 out of 105 patients who received the intravenous furosemide infusion did not respond and required hospitalization, while we managed to save 91 patients from definite admission. And we all know what does admission mean to heart failure. And this is our activities. Now, what happened on April 2020? It was of the beginning of the global lockdown. So everything shifted from the regular standard care to a COVID-19 care. The whole team was redistributed between ER and inpatients and so on. And most of the program activities were on hold. Trying to face a ghost that we know nothing about and trying to be with our colleagues. But then a couple of months later, the hospital statistics start showing stunning results. There is a tripling of ER visits, hospital admissions, and ICU occupation for non-COVID-19 patients by decompensating heart failure. So you can imagine the amount of deterioration of our cohort. By the way, our service looks at almost 500 plus patients on a regular basis, and we have more than 1,000 visits every year as an outpatient. So based on that, a decision was done, and then we started reassembling the program team, reopening the heart failure clinic, and unfortunately, it was almost 95% of our patients that start coming to the clinic, coming back, are decompensating and requiring our IV diuretic room just to prevent their admission. And then, alhamdulillah, around mid-August, early August, we started to look at rates that was before the era of COVID, and we're back into our regular service of saving actually our patients from deterioration and from occupying hospital beds that are highly needed for COVID patients, and from their definite deterioration once their admission. Now, finally, this experience that I'm showing carries a simple message, is that heart failure programs are really effective when it comes to a regular routine work. And with our experience and what I showed you, it showed that it is an extremely important entity in preventing deterioration of such a huge cohort of heart failure patients during the COVID era. And we're very proud of what happened, and thankfully the rates and the patients started to be saved again. So thank you very much for your time and listening, and I think we'll give back to Dr. Fakhr now.
Thank you very much, Dr. Kamal. It's a very nice presentation. And as you said, there is the role of all the specialist healthcare professionals in such a treatment. As you said, it's a pandemic era. We didn't know what we are doing. We don't know what's right and wrong. And that's why it took us to the role of clinical pharmacists, which I'm going to be presenting now.
Yes,
Kamal, I think you said you will present me. So I'll
yes. I'm insisting actually on presenting Dr. Fakhr with all pleasure and honor. I would like to present Dr. Fakhr al-Ayyubi. Dr. Fakhr is the president of the Cardioclinical Pharmacy Group at the Saudi Heart Association and vice president of the Arab Association. At the same time, she is an associate professor at King Saud University. So pharmacist new rule during COVID-19 is the topic. And Dr. Fakhr, the screen is yours.
Thank you so much, Dr. Kamal. Well, I'm glad to talk about our experience, regardless what specialty we are. Honestly speaking, it was something unique. Maybe this pandemic thing happens like in every 100 or 150 years. We don't know. But honestly speaking, we learned a lot on all aspects, not just on the professional aspects, even your life and your social life and so on. But what I'm going to focus on actually is the role of pharmacists. And why I'm talking about pharmacists, because as you said, we need to collaborate, we need to work together to save our patients in the end. COVID has been introduced by Dr. Faiz. It is a problem. We had a lot of queries around. We had a lot of questions that we have no answer for. Healthcare practitioners and pharmacists are responsible to deal with it, regardless, is it a ghost, is it not? We don't know. And to be honest with you, we had a statistic telling us 70% of our patients were not coming to get their service, and it was only the urgent cases. We were stopping them from coming to hospitals, although before we used to complain about patients not complying to their appointments. And that's not all, of course, because of the pandemic problem, we had an economic problems, which means that a lot of staff were not getting their salaries sometimes, we're cutting off some of our staff, but we still need to survive. So pharmacists said we will stand up as much as we can, and we have a very important area that I will focus on the coming few slides. Some of the immediate actually challenges that we face is that, as I told you, the staff number is less. We need to protect our own staff first, and we need to protect our patients, because some of the area, like in the outpatient pharmacy, we see hundreds and hundreds of patients coming. So imagine that you need to protect them also from getting COVID-19. The other thing is that we had a lot of barriers because lots of systems were actually very difficult to control. We need to restrict the number of patients who's getting their medications. We need to also focus on the personal protective equipment on our own staff and our own residents and our own patients. So there was a lot of challenges that we had to face. And also, of course, the most important thing is that we need to work on the disease itself. Now, as Dr. Kamal and Dr. Faiz were telling us about chronic disease, these diseases usually patients used to come for a follow-up. Well, these patients, we don't need them to come during the COVID-19. So we said, okay, we need to stand up, we need to do something. What we did is that we did something called the virtual clinics, where pharmacists were assigned for it, for specialized clinic like anticoagulant, diabetes, cardiovascular, heart failure, and so on. We were doing the reconciliation for those patients. We were working on the patient's counseling, but not face-to-face, through the telephones, of course. And the most important thing, we were taking care of the patient to take care of himself. We don't want them to count on coming to the hospital or coming to the ER. Unless there's an infection, don't come to the hospital. Unless there's an urgency, don't come to the hospital. That was our clear message to our patients. And that's not all. We need also to work on the treatment of the COVID patients who were admitted in the ICUs and in the wards in the hospitals. And we all know that there's no clear treatment for those patients. So our job was to focus on, first of all, in the hospitals, we need to work on the update information. We need to work on the regulations and the policies for treatments of COVID. Again, we're not talking about treatment of COVID as far as we're treating the outcomes, the sign and symptoms. The other thing is that we really need to work also on the clinical trials. Some of the drugs were used as an off-label because of the crisis itself. Again, we need, as a pharmacist, to bring up the safety profile of these medications. Are we able to use it or not, especially in the antivirus era, and the infection part, in the sedation, in the ICU settings, and so on. The other thing is that we really need to focus with the physicians, of course, on giving the proper medications. Now, proper medications means we have to work on the dosing, interactions, and so on, which I will talk about just a few slides, in the coming few slides. Now, the point here is that in the emergency, we can work there with the whole team, of course, but we also need to work on another thing, which is how can I catch the patients at home? The MOH in Saudi Arabia, and I'm sure in other countries, they have the same thing. They had a campaign. First of all, they set the protocols that was almost maybe edited 13 times, because every time they say that hydroxychloroquine is the drug, no, stop it, go to cortisone, go to dexamethasone, and so on. So these different, we can call them policies to manage COVID patients were for everybody. It was through the MOH. Nobody at that time was actually raising any kind of policies to not really need to interact with each other. The MOH had the lead and all the sectors around to work on a campaign called "We Are All Responsible." It's not just actually the pharmacist or the physician or the nurse, even the patients themselves in the public, they are supposed to work on how to avoid catching COVID. The other important thing is that once you are protecting public, you are controlling the pandemic problem. And you can see from Dr. Kamal's slides that the number of deaths of COVID patients in Saudi Arabia were little compared to other countries, which means that we did it successfully. The other thing is that we need to encourage also the public to read a proper and scientific information about the disease. Where are we? How we can catch the problem? How can we deal with it? And so on. The other thing is that ambulatory care, which I mean the ones, the clinics, the VR clinics that we used to do in the hospitals. Now we call them ambulatory care clinics because part of it is the outpatient dispensing era. At that time, we activated something called the drive-through pharmacy service, where in this case, patients were not coming to the hospital. Either they come through a drive-through, so they don't enter the hospital. The other way is that to activate the application to the mobiles in order to put the patient's medication, send it to them home by mail so that we make sure they don't come to the hospitals, which is a very successful story for us in Saudi Arabia. In hospitals, as I told you, we were part of the team in the ICU, in the ward, even in some of the ER setting, where we have to work together with the physicians and nursing to tell about the drug interaction, the maximum dose, the minimum dose, the side effects. There's any form or formulation that could be helpful for patients who cannot swallow or old age and so on. We also need to work about the investigational drugs and give more data about it. The off-label, of course, information, it's part of our job to work it with the other team. The, all kinds of drugs that we covered at that time, the antiviruses I told you, the even the cortisone, the immunosuppressive medications, and so on. So we had to work very hard to give the proper, at least, information. And of course, the group age, which are very special, like pregnancy, children, and patients who are having comorbidities, how to deal with the whole situation, not just the COVID part only in these patients. Of course, in the remote countries, we used to work with the virtual clinics, and it worked very well. For example, Negative, they had to stop, of course, all the services. It was locked for some time. We had to do a point of care anticoagulant follow-up, and it was a very successful story. Patients really were monitoring their INR at home. What about community pharmacy? And this is the beauty part about Saudi Arabia. We had a very nice, actually, courses for our community pharmacists outside. Thankfully, they were very helpful at that time. They used to give the medications, which are the chronic medications for the patients who are stable. That's not all. They used to also help in managing chronic problems and disease by giving the proper dosing. Sometimes they help also in the OTC medications. And also the pharmacy group, either with the heart failure group or the specialized clinical pharmacy group in the Saudi Heart Association. We did actually our own protocol and medications for the guidelines of this current condition, and what is the medication that should we put our patients on, with, of course, a proper review and update information for each drug and each dose and each group of age. We were also having the chance to talk to the public. Part of it we had, as Dr. Faiz was telling us, we have a problem in the diabetes part in Saudi Arabia, and we were able to talk to the patients about the lifestyle, the proper food they should take, sometimes even predicting the pre-diabetic part, which actually was activated through the COVID era. And also some medications were really helpful. And also we raised something very important that Dr. Abdullah will focus on, about the cost analysis of this pandemic time. It's very important to measure the direct cost. Also, what is that? What does it mean? We will focus about this in our coming webinar, which is the pharmacoeconomic webinar. And also we focused on the pharmacovigilance part, which is the safety of these medications and what is the outcome. Courses were done online to educate our pharmacists in all sectors, in all over the kingdom. in order to tell them how to talk to the patient, what's the proper actually medications they should be on, what's the dosing, the update, and the guideline. We had a great collaboration with all those societies that you can see on the board, national, international, European, and American, and all kinds of collaborations in order to make sure that we are updating our pharmacists with the most updated guideline for the management. The last point is the digitalization. I do believe that it was really the time for digitalization, which is outstanding. It helped a lot in counseling the patients. Of course, in our also health profession, we used to do everything manually. Now it's all digitalized. All our meetings or our conferences or our discussions were done through this networking. And it was a really novel approach. We had to do it. We were scared of it a time ago, but now we are so familiar with. As you can see, our webinar is through this digitalized way, which is giving a very good outcome, I believe. I believe that still we have lots of area to work as a pharmacist and specialized, of course, healthcare professionals. It's not the only area that we did. I'm sure there's a lot to do. We will cover about the networking very soon. In December, we will have our networking conference that I hope all of you can attend, and it is for all healthcare practitioners, not just for pharmacists, to tell us about how can we utilize the skills of all the professions. The most important thing, how did we really face such a problem? When we had this COVID problem, it was something new, at least for me, our generation. We never saw something like that before. Okay, what did we face? How did we handle it? How did we really isolate the problem and focus on having the proper solution for it? In global healthcare, we have proved as a pharmacist that we did a great job. And I do really focus now on digitalization and all aspects to improve the patient's outcome, to improve also the patient's care. And I really want to thank you very much for giving me the time to talk about this. I think now it's the time for Prof. Mohammed Osama to take over from me. So, Prof. Osama, just let me take the chance to introduce Prof. Mohammed Osama. He is the Dean of the Egyptian National Heart Institution, and he was just inviting us to come to Egypt, inshallah, very soon for his coming, inshallah, conference, Cardio Egypt. Dr. Osama is a colleague of most of us, and he's our pioneer in cardiology in Egypt.
Egypt and COVID-19, what happened to the practice? Here, coronavirus, this slide shows what happened during the first half of this year. Since coronavirus started as pandemic crisis all over the world, it started in Wuhan. Till April 2020, 2.5 million cases all over the world. Natural disease course is still unclear, but there is vulnerable patients with severe disease, with coronary artery disease, with increasing age, with smoking, diabetes mellitus, and immunocompromised patients. Infections increase the risk of acute coronary syndrome and heart failure. The mechanism in cardiac patients is increasing acute coronary syndrome in a form of increasing myocardial demand, lead to myocardial injury, lead to type 2 myocardial infarction. Systemic inflammation increase the systolic, increase the circulating pro-inflammatory cytokines, lead to atherosclerotic plaque instability and rupture. This we can in these two studies we can show that to the right of the slide. This is the first study showed by Shah et al. You can recognize that the incidence of mortality is 4.5 between the patients without coronary artery disease. Whenever troponin is elevated, the mortality increasing by 10-folds to be 51. The next study was GO in 2020 as well. he stated that the incidence or the mortality is 8%, increasing in patients with coronary artery disease. If the patient is having coronary artery disease with normal troponin, the mortality will be 13%. With increasing troponin and negative history of coronary artery disease, mortality 37%. If the patient is having positive history of coronary artery disease and the elevated troponin level, the mortality will be around 70%, which is a very important crisis. Yesterday, we have worldwide around 34 cases, 34 million cases of COVID, with 1 million mortality in between them, and the 25 had been recovered. And yesterday we heard about that the president of USA has been infected as well. USA is still ranking #1 all over the world with 7 million cases, with overall mortality around 220,000 deaths. India ranking #2 with 6 million cases. Egypt ranking #38 with total number of 103,000 cases and total mortality of 5,000 cases, around 5. The mechanism, or what is happening actually, 20% of the hospitalized patients having cardiac involvement, 50% mortality if the patient is having cardiac mortality. Silent hypoxia leading to pulseless electric activity due to hypoxic respiratory failure, pulmonary embolism, cardiogenic shock with pulseless electric activity, myocarditis, and cytokine storm. All of these lead to multi-organ failure. Arrhythmia with COVID, torsade de Bonne, ventricular VF with COVID-19 cardiac involvement, primary arrhythmia syndrome exacerbated by COVID-19 illness. Arrhythmia with delayed care. All of us recognize that the delayed care because of the business of the ambulance, the fearness of the patient to be transferred to the hospital, delayed arrhythmia care, myocardial infarction, and with delayed care and ischemic VF at home. In National Heart Institute, we have a number of cases, around 2,000 cases per month. This number dropped by January, started to drop. In blue, you can see the number of coronary angio, and in yellow, you can see the number of PCIs. You can recognize that during April, May, and June, we have the nadir of the curve, and the number of the coronary angios and PCIs dropped markedly to start to recover during July, August, and September. Also, this is the number of pacemakers in green color, electrophysiological studies in blue, and pediatric cases in yellow. You can recognize that the pacemaker dropped significantly. And actually, I don't think that the incidence of heart block had decreased during these 3 months, but actually the fearness of the patient from coming to the hospitals. And we started the recovery during July. But still till this moment, the pediatric patients didn't recover because the fearness of the parents about their sons and daughters. We didn't recover the number till this moment. This is the total number of the coronary angio and all types of cardiac catheterization we are doing in the National Heart Institute. In January, the number dropped to 1,400. This number is still going down till April, May, and June. This number recovered during July, August, and September. Also, the cardiac surgery patients dropped from 300 per month last year, starting to drop to 260 during January. This number is still dropping till April, May, and June. These cases, all of these cases during April, May, and June were emergency cases. Dr. Faiz showed this. Dr. Faiz and Dr. Kamal showed slides just like this. One, what was said about the ACE inhibitors and ARBs. We heard about what is going with these drugs, but we didn't stop using these drugs, or we didn't change the doses. COVID arrhythmia. Multiple mechanisms of sudden death. Role of VF in COVID and sudden death not clear till this moment. Low rate of arrhythmia observed in COVID patients if they have no history of coronary heart disease or myocardial infarction. And we are giving anticoagulation during COVID started to be a routine. Hydroxychloroquine therapy for longer recommendation. It is known to have a pro-arrhythmic effect. Ramoxifene has a limited pro-arrhythmia risk, but it's still having a risk of arrhythmia. Risk of delayed cardiology care, sudden death from VF with myocardial infarction at home. New normal arrhythmia care while protracted COVID-19 procedure pre-testing for COVID universal precautions, because we stopped all elective cases. The routine is what was doing. We were doing all patients checked for troponin, and all patients admitted to hospital. I don't think all hospital did these checkups, high sensitivity troponin and pro-PNB. I don't think all hospital did these investigations. Check inpatients, check every other day. We were doing this in our patients because our patients were cardiac patients. If high sensitivity troponin more than 200 nanogram, obtain 12 read ECG, do point of care US focus echo, and either abnormal obtain virtual bedside cardiology consultation. We are doing bedside consultation or virtual. If no new ECG, echocardiographic abnormality, continue to monitor high sensitivity troponin and NT-pro and BNB. The World Health Organization has stated that what is about the mild and severe cases? I have the problem of mild and severe cases in my patients, and also from my point of administration, I have the point of mild and severe cases in my doctors and nurses. The World Health Organization has stated that people with mild cases can expect recovery to take 2 weeks, while those with severe cases may take up to 6 weeks to recover. But this distinction between mild and severe cases is confusing, and many of them are experiencing symptoms for longer. We couldn't expect how much it will last for each patient. Post-exertional malaise, or they are saying it crash or collapse after even small amounts of mental or physical exertion, that was previously tolerated. Many of my doctors or my nurses experienced post-exertional malaise, and this caused me many troubles in rearranging the schedules and the duties. This is the chronic fatigue syndrome. This is a study was done before COVID, but actually I found it suits the data suits what happened after COVID. Chronic fatigue syndrome is a neurological and immune system, endocrine system, and energy metabolic system. Chronic fatigue syndrome is a fatigue loss of memory, lack of concentration, headache, and extreme exhaustion. And this was my trouble with many of my nurses. A high number of pro-inflammatory cytokines, actually it is in COVID, have fatigue and flu-like symptoms, increased number of natural killer cells. Myocarditis also is a part of the COVID syndrome. It is about 20% of cases. Troponin is not a routine biological parameter in hospitals with COVID and not in our National Heart Institute. But it is important in cases of ECG changes, chest pain, or echocardiographic abnormality. Coronary angio to exclude acute myocardial infarction. We don't know what is causing prolonged COVID. Is it the ongoing initial illness, or is it an inflammatory reaction, or is it a post-viral syndrome? We don't know what the prognosis is and what the long-term consequences are. Actually, this troubled me in my patients and in my colleagues as well. Egyptian cardiac experience in National Heart Institute, what happened with us during this period of COVID? The total number of cases in the reception room, emergency room, decreased from around 8,000 cases per month to less than 1.6 thousand cases per month. The presentation of cases was delayed for logistic reasons and the fear of the patient from hospital admission. The idea was to give thrombolysis in suspected cases rather than primary PCI. In some cases in Egypt, and some centers in Egypt, it was preferred to do pharmacoinvasive strategy. In pacemaker implantation, in suspected cases, we did VVI pacemaker without temporary pacemakers to minimize the patient movement inside the hospital, then referring the patient to COVID hospital after 4 hours. We stopped the elective electrophysiological study. We did just 2 cases of VT storm during these 3 months. We stopped all pediatric elective activities, but the parents are afraid to bring their sons and daughters to the hospital till now. We stopped chronic total occlusion activities till this month, and we will start it, inshallah, during this month. We did the first mitral day last Friday. We did 15 cases. Regarding coronary angio and BCIs, we could pass the nadir to reach our numbers of January and February. Regarding the outpatient clinic, the number of patients has decreased from 1,500 per day or up to 2,000 per day to less than 500 per day. Most patients were coming just to take their routine monthly prescribed medications, and we were giving them the quantity which could cover them for 3 months. We did not stop acute ACE inhibitors or ARBs or even change the dose, as Dr. Faiz said. All the reception room and the outpatient clinic were following the full instructions of the infection control and quality control teams. Thank you.
Thank you very much, Prof. Mohammed, for this great information. Amazingly, that you said the number of patients were decreasing from 1,500 per day to 500, which is actually the maybe full number of 1 week in our clinics. You're having a huge number there. Wishing all of them, of course, a healthy life. Now it's the time for Dr. Abdullah Abu Talib. Dr. Abdullah, I want to thank you personally for actually having this meeting gathered, or with all these great distinguished valuable speakers, for also introducing Prof. Muhammad Osama for such a webinar with this great information. Dr. Abu Talib is our WHO founder. He is actually very expert in numbers, and of course he will talk about money and about lots of information that we really need to focus on now. We said about our practice, we took some time to talk about our experience individually and in some institutions. But the good part about Dr. Abu Talib is that he will tell us about the MENA region, a big gathering information that we really need to see, did we do good? Are we doing a good job or not? So Dr. Abu Talib, go ahead and start, and the podium is yours.
Thank you again for Saudi Art Association for giving me the pleasure and inviting me for this magnificent and thoughtful meeting. My name is Abdullah Abu Talib. I'm working as a project manager for WHO European region. And since 3 months, I became a senior consultant, and my specialty is healthcare reforming and policy analysis. And my presentation today, the impact of COVID on cardiometabolic practice in the MENA region, especially and pre-diabetes management. What is the analysis? What is the recommendation? Hoping that my presentation will answer for something, sending message for others, and sharing the experience. This project was done through my team in European Observatory, one of the health system on health system policies. One of the partners was WHO. The objective for this presentation is what is the impact on pandemic of COVID-19 on the practice of cardiometabolic? What is the future in the cardiometabolic practice in the MENA region? This is the first wave. The second wave will be low and middle income countries, and the second wave will be in international countries, high income countries. Why I'm doing this? Because if we didn't know what is the impact, we will not know what is going in our policy, what is our policy will face, what we will do in the second wave of COVID, which definitely will become very soon. My project was done through different countries like Algeria, Morocco, Egypt, Lebanon, KSA, United Arab Emirates, and Turkey to find our recommendation. And there is that I'm sharing the knowledge, and let me share with you why you are doing this. We have a framework for the project. One of the main items for the framework of the project, and one of the points that I'm focusing in, and one of them is reallocation of resources, what will happen and what happened during this hard time of pandemic, and what happened to the staff, ensuring that staff is trained and well supported to deal with emergencies, and what is the consequences for pandemic, and what it will the impact and consequences in changing the clinical practice and healthcare protocols after COVID, which will be definitely changed. We will see the elements that play the role in management of COVID and the cardiometabolic. Let's see. We started with health system capacity. This is the main elements affecting and influencing health system capacity. And one of the major players is effective policies for quarantine. If we don't have an effective policies, the all consequences after that might not be sufficient enough or efficient enough. One of also main player and affecting and influencing the health system capacity is healthcare professional workforce experiences. It doesn't matter how many healthcare professionals you have, but the matter is how many trained healthcare professionals you have. Training is very important, raising the skills for management, the situation during COVID. If you have a healthcare professional workforce with high number, without well-trained, without effectiveness and efficient policy, you will have a lot of mortalities. You will have a lot of mortalities of your team. You will have a losing of your resources. So what is healthcare professional, trained healthcare professional will impact and influencing your health system respond to COVID, especially cardiometabolic, with the countries with high incidence and prevalence for cardiometabolic disease. why we started doing this project with integration between cardiometabolic, because you know that cardiac diseases are combined with metabolic diseases, and cardiac and hypertension and cardiac problem and diabetic problem are mainly influencing health system and pressure on health system in our MENA region. So our project is trying to analyze what will happen in the future and what's happening now and what is recommendation. This is the methods. We have an integrated analysis between ESC guidelines, ACC, NHS, WHO guidelines, conducting local surveys, conducting local data, making one-way scientific analysis because we are going in a variable and cohort studies. Scientific analysis is a dimension and tool showing us what is going on and if we are going right or wrong. And this is the result. The following result was founded, and this is number of services decline for cardiac patients. And this is, I think, emphasizing the previous slide for Dr. Osama about what's happening in the services during COVID. And this is unavailability for cath lab medical staff during COVID. And this is the algorithm for outpatient appointment for prioritization for a specialist diabetes department during the coronavirus pandemic. They made a prioritization, they made an algorithm, they made a patient journey, urgent face-to-face, and what is the consequences from diagnosis type 1 diabetes, urgent insulin started, blood testing, monitoring, where physical examination essential like monitoring or food, ulcer, infection, pregnancy, and if virtual telephone, and we will see the impact of technology now, what would the use of virtual meetings, follow up, what is the technology used, and also the fear appointment, patient diabetes is stable and will manage it, all face-to-face groups, structured education courses, all flash, glucose monitoring, start sessions, risk of attending appointment greater than benefits. And this is the ratio of technology solutions at low and middle income countries and technology in MENA region. If you see the difference during April, what was the peak of quarantine and locking down, the curve in MENA region is go dramatically high. This means technology solution might have a role in supporting practice and supporting health system, but in low and middle income countries, a lot of difficulties facing using technology, so the growth was not as expected. But there was a last publishing for Cochrane Library digital contact tracing technologies in epidemics, a rapid review. I recommended to read this full article, and I selected author conclusion: the effectiveness of digital solution is largely unproven, as there are very few published data in real-world outbreak settings. This leads to us for registering and putting all the data we have into a publication. We need to share the experience. This is why you are gathering and collecting such kind of events. Why I'm giving you this author collection, because if you go to the methodology, they just found 6 studies only the impact on technology. We have a lot of data. We're in a dynamic situation. We need to publish. We need to extract, to share the knowledge. And this is providing healthcare service effectively between low middle income countries and MENA and Germany. We started for many points. One of them is planning service, and the second point is managing cases and maintaining essential service. If you see between MENA and Germany, I think why I choose Germany. Germany was one of the most effective countries leaded Europe for managing COVID pandemic. In MENA region, we are not far from Germany in planning, but I think we little bit far in maintaining essential services, sustainability of the health service system. This is why we should working on this. This is the objective of this meeting and other meeting. And adaptation of elements of cardiometabolic practice. This is the elements are affecting and adopted during the pandemic. One of them is prioritization criteria and time reducing for services and technology solution, medication plans, and minimizing intervention procedures. And we will go to medication elements, reducing time, medication with high safety, hospitalization time, and technology solution. We will go to this element into the part of prophylaxis treatment. What is going on prophylaxis treatment in the era and the concept of pre-diabetes. Why I choose pre-diabetes? Let's see together why I choose these items and what is the impact of pre-diabetes management in the MENA region. This is one of the cornerstone treatment plan for pre-diabetic is metformin with pre-diabetes. This is a consumption and use during the COVID pandemic in the MENA. This is February, March, April, May, June, July, August, September. And what about comparison between metformin with pre-diabetes in MENA and UK? In MENA, there was no significant growth, as you see in the shape and the chart. I didn't find a clear reason. This is why my suggestion for you, for anyone who would like to going with the task force with Saudi Heart Association, finding out why there is a misconception about using metformin in a wide scale in pre-diabetes management during COVID. It will be a good topic for publishing. Also, I have a feedback that maybe it's due to pharmacovigilance reporting, which need a lot of illustration and need of sharing the knowledge about this announcement. It didn't clear yet for me. And for UK, you will see that the magnificent increasement of the curve of metformin. And when I go in an in-depth analysis for what is the region for this, why UK? Because you could have a strong guidelines for management pre-diabetes from both perspective, clinical perspective and economic perspective. I found that NICE is referring to National Institute for Healthcare and Excellency. They have a type 2 diabetes prevention people at high risk. They have this guideline since 2012, and they have updated at 2017, and they considering their guidelines for the patient high risk, it will be suitable and a suitable tool for management pre-diabetes management during COVID. And they have a recommendation about metformin. Why the committee made the recommendation a healthy economic model, showing that the lifestyle changing program are cost effective for all people at high risk for diabetes, providing support existing recommendation to offer the intervention of the group of people. The model also showing that the lifestyle changing program are particularly cost effective for people with high risk. This is the range for blood glucose level for the pre-diabetic patient, and also lifestyle program was combined with management for metformin. And this is the cost for pre-diabetes management during COVID at MENA. You will see that the costs are going to decrease due to an effective policy for management. But also you will find that cost of diabetes complication management during COVID is raised. This is a sign, this is an alarm that we need to make our health system enhancement, focusing on pre-diabetes management, enhancement pre-diabetes policies. It will have an impact on our costs. This is NHS definition of prediabetes is where blood sugar level are abnormally high but lower than the threshold for diagnosis diabetes. It is estimated that around 5 to 10% of people with prediabetes will go on to progress to full blown type 2 diabetes in any given years, and this is the range for prediabetes marks and remarks for NICE. And NICE making this recommendation and made this recommendation based on prevalence of prediabetes in England from 2003 to 2011, population-based cross-sectional study, and unfortunately we didn't made and I didn't find any such kind of this type of studies in our MENA region, which make a good opportunity for Saudi Heart Association and other association to make such kind of studies. Result, the prevalence rate of prediabetes increased from 11.6 to 35.3 from 2003 to 2011. By 2011, 50.6 of the population who were overweight, body mass index more than 25 and less than 40 years of age had a greater socioeconomic deprivation, were more likely to have a prediabetes. So there's a big problem in UK, and UK learned how to manage with this in our countries based on this study. Based from our experience, I think we have a major problem for prediabetes management. We need to manage it, we need to focus on it, and we need to make some solution for it. And now we are going to diabetes management. What happened in the diabetes management during COVID? First of all, remodeling diabetes services and emerging innovation. It was remodeling during the new solution like technology, new treatment algorithm, and sometimes they go back to the basics of treatment, as you will see now what happened in the management of pre-diabetic, where change seen key differences with COVID, starting with early admission. What is people with COVID infection happen to them? Severe illnesses or admission fluid requirement, what happened? All patient areas, ICU. If you see that any item from treatment elements from the previous presentation are minimizing ICU, which will be favorable for the decision maker and for the system. And also, there is a guidelines and recommendation from Diabetes Care Volume 43 Supplement January 22, and it's implemented for different countries in the MENA about multidisciplinary for choosing what is the appropriate treatment for diabetes. The criteria was based on efficacy, hypoglycemia management, weight change, CV effects, costs, renal effects, and additional information. And we took one of backbones and one of the leaders for this treatment lines and treatment plans, metformin, based on this criteria and all based on the resources we'll use, because it costs low cost for the resources. And we will show now what the in-depth analysis happened to this. First of all, this is the prevention strategy and the impact of prevention strategy and what happened during the diabetic management during COVID. The prevention strategy were increased with significant increase, especially from April, which is a time of lockdown, and also control strategy increased. And this is retinal screening increased to minimizing the consequences of uncontrolled diabetes. And weight check and lifestyle support. Weight check and lifestyle support, one of the major playing elements for this was technology solution and virtual solution for this. And this is the curve of consumption and using metformin in the MENA region during for managing type 2 diabetes during COVID-19. And this is the increasement of the of using this product and protocol. Also, This is the quality of life combined with metformin indication and use. And if you see that this is an increasement of quality of life of the patient, and quality of life is combined with outcome, and quality of life is combined with enhancement of the resources of the health system. So there was a consequences for using metformin strategy. The costs and the economic burden of the health system were decreased based on an effective strategy for using metformin for management type 2 diabetes. The conclusion and recommendation, I will take 3 home messages. One of them is the remodeling for diabetes services and emerging innovation was happened. We need to work and build on this and continuous for the remodeling. I think from my experience, the clockwise doesn't come back in the past. We need to go to the future. Second, the multidisciplinary for using treatment for type 2 diabetes and type 1 based on this criteria is effective and will leading to change the practice. 3, the third message is pre-diabetes management is much more essential to enhancement our health system, and the practice of management of diabetes is focusing on the pre-diabetes management, enhancement their policies, and enhancement its treatment algorithm and patient journey, because it will have a positive impact on reducing the economic burden of diabetes management. And the new value in healthcare is an equation calculating superior outcome, patient-centered care plus efficiency with lower cost. Back to the basics. Hope that my presentation was helpful, and I'm ready for any question. And thank you.
Thank you very much, Dr. Abdullah. Thank you very much for our great audience that are still with us, although it's Friday and it's a family day. It's a very informative presentations. Honestly speaking, I learned a lot. And
thank you.
Dr. Abdullah, I think we will start with you by a very important question, Mike. Now you're talking about preventing the diabetes. I saw from your slides that the UK has increased using it during the COVID time, although in our slides where actually you are measuring the Mena practice, it wasn't increased. What do you think the reason could be?
I made maybe like a survey for my healthcare professional or policymakers in this country. I think Saudi Arabia, one of the lowest country using metformin during COVID, maybe for the pharmacovigilance issue, maybe lacking of awareness or lacking of information about what is the effect of pharmacovigilance report, maybe. Maybe lack of awareness for the value of metformin during COVID, maybe lack of studies, maybe lack of evidence for these countries. So I think this is the role of healthcare professional working on such kind of evidence and developing and delivering evidence for physicians and healthcare professional about what should be used with an appropriate and effective resources. In COVID, there is no health system, we can call it rich. We don't have this privilege. So we need to back to the basics and managing our resources in an efficient way.
Great. Dr. Faiz, you have a question. They are telling us, from your presentation, do you think that COVID will increase the incidence of diabetes?
Yes, because we know diabetic patients are more prone to infection because they have a problem in the immunity. They are having lower immunity than the others, and that's why when they develop diabetic foot or these things, that is very harmful. Also, when you have an acute hyperglycemia, there will be activation of ACE2. With ACE2 is the site of action of the COVID. And ACE2 also is increased in pancreas. And when it is in the pancreas and COVID affects the pancreas, so the insulin will be reduced. And that's why it will just help in new onset diabetes and worsening of the diabetes. This is mechanistically, but we need more studies to confirm this.
Actually, we have only 1 more minute.
I need to ask Dr. Osama, can I?
Yeah, go ahead.
Okay.
Dr. Osama, great job by the National Heart Institute, as
Thank you.
and it was very nice presentation. You are the dean who is lucky, very lucky to face this COVID issues. I don't know what is. I think you face a lot of problem with the cost, with the supply, with the psychological upsets of the team, and some of them they got infected with COVID, and some refrain from work. And also I hear that you cover also the COVID hospitals. You send your doctor to the COVID hospital, and you have losses of doctors, eminent doctors, and younger doctors also in the hospital. I think there is a lot of difficulties. Can you tell us how you just brief about how you manage these difficulties?
Really, it was a hard times, as as you say. I lost Dr. Yusri Kamil, my assistant. We lost Dr. Mohammed Farid Gindi, the ex-chairman of the cardiology department. We lost one of our nurses. The number of nurses who invested with the corona reached around 200 nurses and around 20 doctors. Really, it was too difficult. Sometimes we were going to the institute and see how much people is coming and redistribute them. I have just 30 nurses. I have to start with the hot areas and redistribute all over the less hot areas. Also, I sent many doctors to the ICUs all over the Egypt, from Alexandria to Aswan. We were sending around 20 doctors per month to 10 doctors every 2 weeks. 2 weeks. It was difficult days, but alhamdulillah, it passed and we started to recover nowadays. And we are afraid from the second wave. We asking God not to have another wave. يا رب إن شاء الله ما يحصلش second wave يعني.
الله يرحم الجميع ويجعلهم ان شاء الله شهداء في سبيل طبعا خدمه الوطن.
ان شاء الله ان شاء الله.
Can I have one comment for Dr. Abdullah? One small thing.
Go ahead, Doctor. Yeah, okay.
The guidelines didn't say that we have to give until now for pre-diabetic to give medications. Pre-diabetic is to control by diet, by exercise, by lifestyle modifications. Until now, I don't accept a nice guideline, maybe the one. But when you go through the guidelines, they didn't mention that pre-diabetes should take medications. Do you have a comment on that?
Yeah. For if you go to my presentation, you will find it with the high-risk patients. NICE guidelines are not generalized giving medicine for any patient, because it will be wasting for resources and will have a negative impact on the outcome of the patient. They just focusing on the high-risk patients, and in our countries and during this hard time, the curve of high-risk patients are increased, and all clinical studies about the combination between lifestyle and metformin for pre-diabetic are focusing on high-risk patients with the concentration of blood glucose as they mentioned in the guideline. So they selected, they had a selective criteria, not a generalized criteria.
Okay, great. Thank you very
However,
much.
I believe in it. I believe in
Thank you.
Thank you very much, our great speakers. It is really nice having you. Our attendees, thank you for staying with us till the end of the webinar. We promise you, inshallah, coming webinar talking more about the metabolic syndromes, more collaboration, inshallah, with Prof. Muhammad, inshallah, Osama, and Dr. Abdullah Abu Talib.
Thank you.
Pharmacovigilance, economics, inshallah, is on the way. And I want to thank the Saudi Cardioclinical Pharmacy Group, Saudi Heart Association, for conducting this webinar. I want to thank Merck for sponsoring this webinar. And of course, I want to thank you all for giving us the chance to talk about COVID in its last days, I hope, inshallah. And the coming webinars will just get out of the COVID era and to try to talk about something more fruitful, and inshallah more hope is coming in our career lives. Thank you very much. And
Thank you.
Thank
you.
Subhanallah.
Amanillah.